So I request Dr. Anish to come over.
Yes.
Dr. Anish is actually the other pole of Dr. RK, and I think that's why they match each other very well. Unlike pole attract, so that is
बोला ना कि fear psychosis. Lot of medical practice unfortunately thrives on fear psychosis. So you create actually fear in people. क्योंकि fear create करने से लोग surrender करते हैं. देखा, you become actually literally like a soft aggressor, and वो patient उसको एक down position में रहता है, आप position में रहते हो, आप उसका पूरा benefit लेते हो आप उसका. तो है ना, आपका एक शुद्ध हेतु नहीं है. शुद्ध हेतु नहीं है से लेके तो शुद्ध हेतु का डॉक्टर है ना, मेरा क्या कहना, बहुत एक स्पेक्ट्रम है उसमें. तो ही शुड एक्चुअली यदि किसी ने इससे ये सोचा है ना ऐसा, तो लीना मैडम ने जो बताया कि भी पैरासिम्पैथेटिक, न्यू पैरासिम्पैथेटिक आप नहीं थे परसों के सेशन में, पैरासिम्पैथेटिक दो न्यूक्लियस है ना, एक नया एक पुराना. तो यदि नई पैरासिम्पैथेटिक उसकी इवोक होती है, वो इतना फ्रेंडली तरह से देखता है इस आदमी की तरफ कि अपना इन्फॉर्मेशन शेयर करके वो इसको बोल सकता है कि सर मेरे पास पैसे नहीं है, आप मेरे को पैसे दोगे क्या? So he comes across as a very friendly guy. No, he should take it as a compliment, sir. I am telling you. You take it as a compliment. That you come across as a friendly and benevolent person. If patient could put this kind of request to you, don't take it, as a this one. In fact, I would rate you highly. That you are a person who truly is a friend. You are not a fear causer or an aggressor. कि जिसको वो ये सोच रहा है कि अभी मेरे को बाकी क्या, मेरा बाकी तो केवल खून बाकी है, अभी बाकी तो सब निकाल चुके हैं.
See, what I believe is that when you're sitting in a OPD and you have a patient who's poor, and the patient, wants, that this patient is poor, you can refund that money, but you should not do it. It should not be done in the reception area. You should do it in your room, because the patient who's sitting across should not get this idea that you are giving discounts to X. So the rule, unwritten rule in my reception areas, everybody is going to be charged. You have to charge the same rate. There should not be any discrepancy. First visit so much, second visit so much, and nobody should enter my OPD without getting charged, because it's like, I remember we had this receptionist previously. I would say, okay, I'll finish my OPD. I say, okay, patient says, sir, 15 patients, 18. I don't know, I've seen more number of patients. He says, 15 patients. So it's like, the receptionist also tries to do this thing. So two things I did. One is, I made a EMR where every patient makes a bill, and I tell them that the bill should be attached to the file. When the patient comes and sits to me, I can see the bill. So that means there is no goalmar going at the receptionist level. And second thing is, either the patient is paid. See, it's just that you are sitting. Now, if the patient comes and sits in my OPD and tells that I have a financial problem, I'll refund part of the money. I'll not say. I said, fine, you take. There are a lot of patients whom I do it, but that should not be a general rule which everybody should assume that his doctor is going to do it. As somebody says, अगर क्या वो शेयर अगर क्या what's the saying is that ना, शेयर अगर दूध कर लेगा क्या करेगा? The same kind. We are good, but the other patient should not. The patient should not take you for a royal ride. That's
वैसे I think ना आरती actually does it so well. मुझे लगता है इसपे ना वाकई में थोड़ा एक शेड ज्यादा रिसर्च होना चाहिए और अपन करना चाहिए. तो हॉस्पिटल के जो मार्केटिंग वाले लोग रहते हैं ना, उनको जो जैसे ही बड़े ईगो का आदमी दिखता है ना, तो वो उसको बोलते हैं सर इससे भी भारी मेरे पास एक 30,000 रुपए का सूट है आपके लिए. 15,000 की रूम तो आपसे छोटे लोग लेते हैं लोकल इंजीनियरिंग कॉलेज के. क्या हो गया है ना कि सी एज वाणी सेड, बिकॉज दिस इज वेरी ट्रांजैक्शनल between the patient and the whole system. तो वो system भी जो है ना, उसका जो marketing company, they have actually become like that. They encash they encash on people's fear, they encash on people's ego. They have found every way to kind of encash.
My cousin works as an ENT. She joined a new hospital. They sent her to Delhi for 4 days training. क्या ट्रेनिंग क्या है? ट्रेनिंग इज हाउ टू कन्वर्ट ए पेशेंट इनटू कस्टमर.
Absolutely.
4 दिन का है ना. उसको मतलब फैमिली को लेके आने को बोलो, नेबर्स को लेके आने के लिए बोलो. दिस इज द ट्रेनिंग दैट गिविंग. मैंने सोचा ENT का ट्रेनिंग दे रहे हैं. दिस इज जस्ट
तो इसलिए ये दो
दिल्ली 5-स्टार होटल में रखा, 4 दिन ट्रेनिंग दिया, सिर्फ इस ट्रेनिंग. एक पेशेंट एक बार आपके पास आ गया ना, तो उसका पूरा फैमिली कैसे लेके आना है, दिस इज ट्रेनिंग.
वो इसलिए ये दो अलग पर्सपेक्टिव है. एंड एज अ डॉक्टर कोई आता है पेशेंट और मेरे सामने मेरे कोई ट्राई टू पुट मी डाउन, तो उससे क्या होता है, ऑब्वियसली एज अ ह्यूमन बीइंग मेरा ईगो हर्ट होता है, मेरा फीलिंग टोटल अलग होता है. पर जैसा कि कहा जाता है that you should see the opportunity in the adversity. So the hospital sees the opportunity actually in that fellow. Doctor may feel hurt, but hospital sees the opportunity. अच्छा बड़ा ही वाला ऊपर वाला रूम दिखाओ, रोजवुड सूट दिखाओ, नहीं क्या? तो हमारे यहाँ तो वो खुश है बाबा, नहीं क्या? एक तो ऐसे भी हॉस्पिटल में काम करता हूँ मैं जिधर, वो भी उनको कि वो so doctor may feel bad, system feels good. और system तो उसके आगे पीछे है भाई पूरा, like a hospitality industry. Because उसको जिस तरह से आप ज्यादा कन्विंस करके ज्यादा उससे बिल काइंड ऑफ बनेगा वो. तो इसलिए क्या है कि मेरा क्या कहना है ना, ये बहुत रिसर्च करने जैसा सब्जेक्ट है. और एक छोटी बात मैं कहना चाहूँगा, I try to observe, you know, as part of, because of our background, psychology, psychiatry training. So lot of, I mean, good old time के जो जनरल प्रैक्टिशनर्स थे, पेशेंट का कम्युनिकेशन लेवल और एक ओवरऑल मोटिव, पीपल फाउंड देम एज वे अगेन कमिंग बैक टू ऑटोनॉमिक एज फ्रेंड्स, यू नो. अभी क्या हो गया है ना कि एज मेडिकल पीपल वी आल्सो परहैप्स समवेयर हैव दिस बिट ऑफ एम्बिवलेंस एंड कंफ्यूजन इन आवर माइंड. एम आई फ्रेंड विद दिस पर्सन, एम आई अ वेरी सैनिटाइज्ड प्रोफेशनल, यू नो, कि मैं इससे बस यार केवल उसका मैं और इससे कोई बात नहीं करूंगा, या मेरी क्या रिलेशनशिप है. तो डॉक्टर में भी आप सब ये यू एंड शेड देखते हो. देयर आर जेन्युइन पीपल जिनमें वो जेन्युइननेस है उसको हेल्प करने की, सर जैसे लोग, नहीं क्या? फिर अपने जैसे लोग भी हैं शायद बीच में कि बोल चल यार अपना काम पूरता काम, नहीं क्या? सर ने बोला कि वो शादी के पहले की हिस्ट्री, तो मैं तो बोलता हूँ मैं तो डिमेंशिया का पेशेंट हूँ, मेरे को तो कल भी आया वो आदमी याद नहीं है. तो बोल रहा है कि 5 साल पहले आया था, उसका बताना मत. मैंने कहा तू कौन है, मैं तो तेरे को आज भी पहचानता हूँ. तो इसलिए
No, the problem is, sir, I have an EMR. You know, I'm using EMR for the last 7 years.
Yes, sir.
So I have every patient whom I have seen, I have a record of that patient in my EMR. So you know, the only way, in fact, the only way I can say, I mean, and it will come there, diabetes, known case of diabetes. So the only way the patient can kind of go around the system is to make a new registration and make a new file. The patients who have done so, they're very intelligent. Very, very intelligent.
सर आपके लिए चाय कॉफी कुछ
the next session is on obesity. So what I'm going to do is I'm going to give you an overview because we have a mixed crowd. So I'll just briefly touch on certain aspects of obesity. How big a problem it is, why is it becoming a big problem, how to manage this. I'll be talking about the certain aspect of, I'm going to give you an overview, I'm not going to go in detail about it. And then Dr. Vani and Dr. Aarti are going to talk to you about the behavior aspect, because in obesity, when we talk about management, behavioral therapy is very, very important. Because unless and until you change the attitude of a patient towards his disease, whatever you're going to do for him, it's not going to make too much impact. It's a disease which has very high rate of relapse. We have this phenomenon, it's called yo-yo phenomenon. Yo-yo phenomenon is very, very common in obese patients. The patient wants to lose weight, as Aarti was telling, they go through the phases of contemplation and then action. They lose weight, and then they would have lost 6-7 kilos of weight, and that point of time something happens, and they stop doing everything. Again, they go back to their original weight. So what happens is that when you take the history of this patient, they would have given a history that many times they have lost weight, but again they regained weight. So that yo-yo phenomenon is very, very common, and that is what the real challenge is. Now, if you look at obesity, it's something, it's an entity which is known for a very long time. Look at writings from ancient Greece, ancient India, all of them have mentioned obesity. So, even Shushruta has mentioned this entity of obesity in his works. So, it's something which is known for a very, very long time. The question is obesity really a disease? It's just a simple weight gain, but should you label it as a disease? Way back in 2013, the American Medical Association said that yes, obesity is a disease which has multiple pathophysiological mechanisms and needs intervention to address, to manage it. That is the reason, nowadays we are talking about obesity, because there are so many things which start with just simple weight gain and end up with a lot of complications. How do you assess obesity? The simplest, the easiest way of doing is to use BMI. We have a lot of other methods which are available, but in clinical practice for an average doctor, this is something which is easily done. Every visit you can do it. The reason why we use BMI is one, it has a fairly good correlation in body fat, mortality and morbidity. Two, universally it is accepted by researchers all over the world and by various organizations that BMI is a very good way of deciding what cutoffs, when to intervene, when not to intervene, things like that. We have other methods like bioimpedance. A lot of these wellness clinics, they use these specialized instruments which patient feels very good. Fat 33%, 43%, 23%. The problem with all those instruments is that a lot of them are not validated. There is no standardization. You do not know that particular machine has it been benchmarked to a particular standard or not. You do not know that. You go and do bioimpedance in 10 different wellness clinics, you have 10 different values. That is the problem with it. It's good if you have a machine in your clinic and you're using it on the same patient for follow-up over a period of time. But there is no standardization. So you cannot base a decision based on the fat in the body. That's one thing. The second thing is, there's also something called DEXA, wherein you measure it's very good to look at the intra-abdominal obesity fat. Again, the problem with DEXA is it's expensive, not easily available. So when we talk about a problem like obesity, which is so common, we have to have a easily measurable entity to assess, to document, and to look at the follow-up. Cutoffs, all of us are aware of it. 25 to 30 overweight, more than 30 obesity. This is according to WHO. But Indians have lower cutoff. So this is something which I would like to stress here, that Indians have a lower cutoff because for the same BMI, Indians have more fat compared to their Caucasian counterparts. So anything more than 23 is overweight. Anything more than 25 is obesity. So if you really look at it, probably in this hall, 50 to 60% of us would fall in the overweight category and obese category. So that is something which is very, very alarming. What about the abdominal obesity? For Indians, again, you can see the cutoffs are much lower. 102 for Western population, 90 for Indians. So Indian men, more than 90 centimeters is taken as central obesity. Indian women, more than 80 centimeters. I'm sure most of you who are from Pune know this person. This is Dr. Yagnik, and this is his colleague with whom he has done a lot of collaborative work, Dr. Yudkin from Pune. Now, we call it the YY paradox. Both of these, you can see here, he looks smaller, of smaller frame. He looks little smaller. This person looks bigger, taller, heftier. BMI more or less same, but look at the fat. 9%, 21%. That means Indians have a smaller weight, smaller structure, but their fat content is more. And that is the reason why a lot of metabolic problems are common in Indians. We see diabetes at a very young age. We see a lot of CLDs, NASH, dyslipidemia, all those kind of things. This is one estimate. There are a lot of studies which says about 23% prevalence overall overweight and obesity. That means 1 in 4%. If you look at various states, this is data from ICMR INDAP study, the phase 1 study. You can see here, Jharkhand, this is the urban data, 30%, Maharashtra 26%. But look at Tamil Nadu and Chandigarh, 35 and 40%, which is pretty high. That means out of 2.5%, I mean, every third person is obese. Even if you look at the rural data, it's low in Jharkhand, 4.3, Maharashtra is intermediate, but Tamil Nadu and Chandigarh, pretty high. 20% and 27%. That means it's a huge problem. Again, as expected, with increased affluence, there is increase in obesity and concomitant increase in diabetes also. This is the data from the India. What about the change over a period of time? We look at this figure, this is 1975, this is 2014. Obesity in men. We are at 19th position world over with 0.4 million obese men. In 2014, we are in number 5 positions with 9.8 million obese men. So we have jumped so many positions. There's been almost 25 times increase in obesity among men. What about women? Number 19 position in 2035, 0.8 million. 2014, we are at number 3, 20 million. So again, amongst women also, but obesity increase has been more in men compared to women. Even the same trend is seen world over. This is data from US. Just in 10 years time, 1990 to 2001, you can see most of these areas have a prevalence of less than 10% or some areas 10 to 15%. Here it has jumped to 20 to 24%. Some areas even it has gone to more than 25%. Just in 10 years time. Diabetes has followed the same kind of trend. So whenever there is increase in obesity, there is increase in all related disorders. Diabetes, PCOS, hypertriglyceridemia, cardiovascular disease, hypertension, CLD, everything increases. This is the shape of things to come. We started here, we evolved to this magnificent, I would say, figure, and now we are moving to this category. So we are moving from bad to worse. Why is this? In just 50 years time, there is so much of increase in obesity. Just to give you an idea, if you look at the Native Americans in US, 50 years back, the prevalence of obesity was less than 1%. Diabetes is unheard. Now, the prevalence of obesity in Native Americans in US is more than 50 to 60%. And diabetes is also that high. That means just in 50 years' time, almost half the population has become obese and diabetic. What has made a difference? One is a change in lifestyle. Because obviously, 5 decades, 6 decades, there cannot be so much of genetic change. Genes are same. And obviously, the change, because of this, there is a change in the pattern of the disorders from infectious disease to more non-communicable disease. All this is responsible. You can see here McDonald's, KFC's, pizzas, burgers, you can see the amount of cheese and all those things, right? And in India, I would say that Swiggy and Zomato are going to be the next big contributor to obesity and associated problem. This is a big, big problem. Look at the portion size. 20 years back, today, 210 calories, now it is tripled, 300 calories, 600 calories. So, to burn this 400 calories extra, you have to walk 1.5 hours. How many of us are going to do that? So, that is the reason why, unless there is a controlling intake of food, you are not going to lose weight meaningfully. Look at the size of cold drinks. This is original Coca-Cola, 200 ml. Now we get 2-liter bottles. In fact, you don't get this glass bottle at all. If you have to buy a cold drink, either you get this tin, which is expensive, so people don't buy it. This is 330 ml. They'll buy minimum 500 ml PET bottle. I don't know how many of you are aware that each 100 ml of any of these cold drinks contains 12 grams of sugar. So one 500 ml PET bottle, which you buy, finish it off in half an hour, has 60 grams of sugar, 12 tablespoons of sugar. So it gives you how many calories? 240 calories, just that one particular thing. So these are all factors which are contributing. Again, this is how things were like for 40, 50 years back. It moved on to getting vegetables and groceries from market to everything online. You sit at home, order everything, and you get everything at home itself. So all this have made a difference. So when we talk about obesity, what we need to understand is that there are multiple pathophysiological mechanisms. The most important is genetic. Unless somebody has genetic predisposition to put on weight, to become obese, these factors probably are not so important. The first thing is you have to have some degree of genetic predisposition. And then everything comes into play. Epigenetic mechanism, environmental factors, socio-cultural factors, behavior factors, physiological reasons, etc. Now, all these factors are fairly straightforward. Just 1 or 2 points about some of these factors. Sleep. There has been a correlation that people who sleep less have a greater tendency to put on weight. So adequate sleep is important. Everything else is fairly straightforward. Eating more calorigenic diet, skipping meals and then binging and eating more snacky food and more calorie-dense food, sugary soft drinks, all of them would obviously be associated with weight gain. Psychosocial factors, this will be dealt by in the next session with Dr. Aarti and Dr. Vani. Biomedical reasons. Now, as I said, genetics are very important. I'll just briefly touch on that. Genetics and metabolism, intrauterine growth, medications. Again, there are a lot of medicines which have a tendency to cause weight gain. So, as doctors, you should be aware of these medicines. When a patient comes to you with sudden weight gain, you should be aware. You should take efforts to find out what medicine the patient is on. The how and what of eating. Now, when you talk about the regulation of energy balance and weight, it's quite obvious, if your intake is more than expenditure over a period of time, you are going to gain weight. The rule of thumb is that if you accumulate 7,700 calories approximately, you will put on 1 kg of weight. So if you need to burn, the reverse process has to happen. You need to burn 7,700 calories to lose 1 kg of weight. There are multiple factors at the CNS level which control energy balance. You have all these satiety signals, and then you have the role of vagus nerve, and they have certain hormones like the ghrelin, which is produced by the stomach, which is orexigenic. That means it causes you to eat food, to seek food and eat food. So there's an imbalance between these two which keeps your weight in check. Whenever there's an imbalance, you tend to put on weight. Now, we were talking about this hedonic eating yesterday. When you talk about energy balance, there are 2 centers in the brain, or I would say 2 areas. One is the area which is responsible for the homeostatic control. That means here it is the energy intake is need based. When you need to have energy, you eat food or seek food and eat it. So the center is present in caudal brainstem and hypothalamus, and then you have the hedonic control, which is essentially a center which gives you a feeling of being good. I mean, feeling good when you eat something good. It's the same center which controls or which keeps which is responsible for giving pleasure when you use drugs of abuse and related to sex and all those kind of things. Now, this center is present in the hypothalamus, amygdala, the ventral tegmental nucleus, and nucleus accumbens. So these are the areas which control the hedonic control. Now, what exactly is these two systems are interlinked? This photo kind of gives you a very good idea that your hedonic control or the hedonic area is compelling you to seek cookies, whereas the other one is trying to push you towards the other side. So it's a battle which is going on there. Now, the hedonic system, these are the circuits which mediate the reward response to drugs of abuse. They make food, palatable food, attractive, even when you don't have a need to eat. So it's like, as we were discussing yesterday, you go to a buffet, you have all kinds of things available, you are full, you don't have the need to eat, you already had your fill, but you look at the place where dessert is there, it's tasty, you like the sight of it, you try it out. The same thing which happened yesterday, we had meals, the coffee was there, we just had it, even when we were not needing to, even when we did not require it. And there are other things which, for example, drugs of abuse, sex, which kind of release dopamine from the VTA, which projects to the nucleus accumbens, and that gives you that reward. So that is the reason you always seek good food, food which smells good, which looks good, and you know that which is going to taste good. Many times this hedonic circuit overrules the homeostatic circuit, because that is the reason why even in a fed state you tend to gravitate towards food, you tend to gravitate towards things which look nice to eat. Now, PET studies and functional MRI studies have shown that patients who are obese show a greater response or to food cues than lean person in this hedonic pathways. So, for example, let's say that there is something lying on the table. A person who is obese is likely to make an attempt to taste it or try it than a person who is lean, probably because of the difference in the responses in the hedonic circuit. Similarly, the erectogenic areas in obese patients are not inhibited to that extent as in lean patients after a meal, suggesting. So, what happens is when you start eating, at one point of time you get signals that you need to stop eating. In an obese patient, this signal tends to be a little delayed compared to a lean patient. That's why they tend to eat more calories before they stop. Now, how does obesity change behavior? Now, this is something which has developed over the last few years, that obesity is characterized by a chronic low-grade inflammatory state. Now, a lot of diseases, chronic diseases, have a component of inflammation. In fact, nowadays, a lot of these diseases like obesity, diabetes, all of them have been found to have a low-grade inflammation in the background, which contributes to the pathophysiology. In fact, this particular chronic low-grade inflammation is likely to influence the neuropsychiatric status due to the effect of inflammation on the brain activity and the behavior. If you look at CRP or interleukin 6, they've been associated with depressive symptoms in obese subjects. And studies have shown that post-geriatric surgery, when there is a decrease in, there's an association between decrease in these inflammatory markers and improvement in overall emotional state and depression in patients who undergone geriatric surgery. So there is a link which has been found, this is something which is worth investigating, and that lot of studies going on this particular area. Similarly, when you have this chronic low-grade inflammation in the brain, you have unregulated and chronic activation of microglia. Normally, some amount of activation is fine, but when it becomes unregulated and chronic, that's when there's increase in cytokines, and this increase in cytokines leads to all these problems. There is activation of the neuroendocrine system, there is impairment of the neurotransmitter metabolism, there is alteration in the neuroplasticity and the brain circuitry. So all of these can have a negative effect over a period of time. In fact, there is an association between interferon alpha and major depression. The higher the levels of interferon alpha, the more is the chances of somebody having depression. Now, a word about some medications which can cause weight gain. This is very important because we see a lot of patients who come to us with a history of sudden weight gain. When you see a patient who has had sudden weight gain, it's quite important to ask this history whether they have been started on any of these drugs. For example, many times patient would have gone to a neurologist for a migraine. They would have been started on these tricyclic antidepressant. They would have been started on various anti-migraine medications like valproate, which have a very strong tendency towards weight. So you have to take a proper medication history where you need to look at for these drugs. A lot of diabetic medications have a tendency to put on weight. This is especially important when you deal with patients who have diabetes, because you should be careful about what drugs you choose in a patient who is overweight or obese, because you don't want them to put on extra weight. Whatever benefits you derive by a reduction in HbA1c levels kind of get offset by the weight gain that the patient puts on. So if you put these drugs, the patient has a reduction in HbA1c levels, but the patient gains 3 or 4 kilos of weight. So everything tends to get negated. So at the end of the day, in a diabetic patient, you have to control sugars, but it should not be at the cost of weight gain. That is something which is very, very important. Heart, amoxicillin, certain, obviously all of us are aware of glucocorticoids and even progesterone steroids. All of these can cause weight gain. A word about the genetic component. As I was mentioning, genetic component plays a very, very important role in obesity. Close to 40 to 70% of the risk of putting on weight is genetically inherited. And this particular link is polygenic in nature. We are really not sure which are the genes which are responsible. There have been certain areas which have been picked up, but like any other polygenic disease like diabetes, there are multiple genes which have multiple action. So you cannot pinpoint one particular gene. This is what we are talking about, the common garden variety obesity, the obesity which you see in day-to-day life. That has usually polygenic. Then there are certain monogenic forms of obesity. These are usually seen in children, where you can have an isolated gene defect or you can have a syndromic obesity. For example, leptin mutation in the leptin receptor can cause obesity. And similarly, the commonest form of genetic monogenic obesity is mutation in the MCR4 receptor. We have a drug which is available as of now for this. And then you have all these syndromes like the Prader-Willi syndrome, the Bardet-Biedl syndrome, and the Alström syndrome. All of these have obesity as a major component, along with other problems which are there. Usually we see monogenic obesities and these syndromic obesities in children, we don't see them in adults. This is a concept which is developing of late, something called metabolically healthy obesity. So what does it mean? What has been observed is that every obese patient is not at high risk of metabolic disease. There's some patients who are obese but have no problem, in the sense like no disease process as such, no diabetes, no hypertension, no NASH, no dyslipidemia, nothing is there. So this is a concept which is developing. As of now, there's no clear-cut definition to say what is this metabolically healthy obesity. But essentially what most people agree is that somebody who is obese by BMI but has no abnormal medical markers. Now, it may be that these patients are more physically fit. The question is, should you label these patients as diseased or not? Well, again, what is believed is that even if an obese patient has no metabolic abnormalities, he or she is at risk of developing these problems in subsequent years. So just because somebody is obese and all their tests are normal, you should not tell them that no, not to worry, you are absolutely fine, you can go back. You should still consult them, should still talk to them about lifestyle modification, because they should make an attempt right at that point of time before they have developed any metabolic abnormalities, rather than developing diabetes, developing dyslipidemia, and then making an attempt to change their lifestyle. But at the end of the day, if you have a patient who's lean, who has all these metabolic risk factors, versus an obese patient who has no metabolic risk factors, what should be kept in mind is that any patient who has a definitely abnormal metabolic markers, irrespective of the BMI, is at higher risk. That is something which is very important. So you have pre-diabetes, you have NASH, you have dyslipidemia. Definitely that patient is at high risk, irrespective of the BMI. Yes, if the BMI is high, which tends to increase. At the end of the day, genetics and your lifestyle makes a lot of difference. Now, what about diabesity? Now, this is a term which is coined because there's a very strong pathophysiological link between diabetes and obesity, and these two disorders kind of was seen to run together. When there was an increased prevalence of obesity, there was increased prevalence of diabetes. In fact, most of the time, if you look at our patients or in general, about 2/3 to 80% of diabetic patients will have obesity. That is because it's such a common association. The reason why we are more worried about obesity and diabetes is because of all these reasons. They tend to have high degree of insulin resistance. So what happens is, you need more number of drugs, you need drugs to specifically target insulin resistance. If these patients are on insulin, the requirements of insulin tends to be high because of insulin resistance. Even when we use insulin sensitizers in these drugs, then also they need more amount of insulin. They tend to have higher morbidity. The cardiovascular complications tends to be more. A lot of obese patients have very poor exercise capacity. Most of them, I'm sure you would have come across these patients, they say, "Sir, doctor, I cannot walk." Because even if they walk 100 meters, they start panting because their exercise tolerance is poor. So you have to be, you need to give them proper advice of slowly stepping up the exercise rather than starting with 1 hour per day. They will not be able to do. The chances of malignancy in obese diabetic is much higher compared to a non-obese diabetes. Complications, I'm not going to go in details about these. All of us are aware of these complications, right from pulmonary diseases, NASH, polylithiasis, various gynecological abnormalities, osteoarthritis, skin issues, gout, varicose veins. Some cancers have been linked with obesity, pancreatitis, and obviously all these metabolic disorders. Everything, lots and lots of disorders have been linked with obesity. Now, so this is one way of looking at it. The other way of looking at it is categorizing them into various categories. So you have metabolic disorders like pre-diabetes and diabetes, metabolic syndrome, NASH, cardiovascular complications like dyslipidemia, hypertension, CV disease, then organ-specific or metabolic complications like PCOS, which is a very common associate of obesity, male hypogonadism, androgen deficiency, OSAs, osteoarthritis, stress incontinence, gastroesophageal reflux disorders, and then obviously all these psychological complications, which again is going to be dealt by Dr. Vani and Dr. Aarti. Now, when a patient comes to you in the OPD, and the patient comes and tells you, "Sir, or ma'am, or doctor, I'm putting on weight, or I put on a lot of weight." So how do you start evaluating that patient? So these are the headings under which we look at it. We start with basic medical history. In medical history, what's very important is the pattern of weight gain. If somebody has been obese from years, from childhood, and they're just gradually putting on weight, that patient is more likely to have the garden variety of obesity, what we see on a day-to-day basis. Somebody comes to you and says that, "Doctor, in the last 3 months, I put on 10 kilos of weight." And that is where your angina should be up. Is there any other problem which is causing weight gain? What are the causes of this sudden weight gain? Obviously, the causes would be disorders like hypothyroidism, Cushing's, and then certain drugs. As I said, we commonly see the patient would have gone to a neurologist with the history of migraine. They would have put on valproate, they would have put on amitriptyline, and they come back with weight gain. It's a very common thing. So you need to make an attempt to ask history of what medicines they are on. If they're a diabetic patient, the patient would have been put on certain drugs which cause weight gain. So the pattern of weight gain is very, very important. In fact, in history itself, we can rule out a lot of disorders. The common problem is that when a patient comes to us, I'm sure the same thing is true for most of the doctors here. The first sentence the patient comes and tells us, "Doctor, I put on 10 kilos of weight. I think I have some hormone problem." So let me be very clear here that probably 1% of the weight gain is because of hormone related issues. 99% of weight gain is because of the garden variety of obesity, which is simply because there is increased intake of food over a period of time and less amount of exercise in a genetically predisposed person. That's something which is very, very important. So the history will tell you whether you should look for these things or not. Physical examination. Now, when you look at physical examination, normally what we do is we look at certain things. We look at goiter, it's there. We look at things like facial puffiness. We look at certain features. The patient comes to us with sudden weight gain. We look for stigmata of Cushing syndrome, whether they have striae, whether they have bruises, whether they have buffalo hump, moon faces, and things like that. But as I stressed, that these things are very, very uncommon. They are not so common. Probably less than 1% are because of this. in last so many years of practice, I would have seen maybe 10 cases of Cushing syndrome. 20 years of practice. So it's not so common. I would have seen thousands and thousands of obese patients. So don't jump to a conclusion that a patient who's sitting in front of you has a hormone problem. Always assume that it is the normal variety of obesity and there may be a possibility that there may be something else. So those are things we look at physical examination. And obviously, we look at complications. For example, somebody has osteoarthritis, somebody has varicose veins and things like that, gout and things like that. Lab tests. Now, when you see a patient who has obesity, we just do few basic tests to just get an idea what are the metabolic derangement. You don't need to do too many high funder tests, just some basic tests. And just talk about that in the next slide. Similarly, you look at, now we know that these are the complications that is, we look at those things in the review. And this I already mentioned. When you're talking about history, the other thing that you have to look at is, you have to look at what kind of eating pattern the patient has, whether the patient is physically active or not, because those things will help you assess how easily the patient is going to, agree to whatever you are going to tell him about lifestyle modification. Now, somebody who is sedentary for whatever reason, somebody who is has this habit of binging and things like that, you will have to probably put in that extra effort to make a change in their lifestyle. Now, these are the things which you look for, as I said, physical exam. This is what? Somebody can tell me? Yes. This is something which will be seen in almost all diabetic patients. Acanthosis nigricans, blackish, velvety change, seen in commonly around the neck, axilla, groin area. Very severe, you can even see it on the knuckles. It's a marker of insulin resistance. So, this tells you that this patient is probably at high risk of complications subsequently, especially diabetes and things like that. What are these? Skin tags. Again, same kind of association, sudden increase in skin tags. So I'll just show you 2-3 cases just to give you an idea. But now we have a 43 years old male patient, diabetic for the past 5 years, who's put on a lot of weight in the last 1 year. She was fairly well controlled. The patient is on glimepiride, metformin, pioglitazone. Now, when you see a patient like this, you've done the basic tests. So, probably the slide is going to come later. So, you've done these tests. So, what do you think could be a cause for weight gain in this patient? Certainly, is put on weight. Yes. So, pioglitazone is a drug which is notorious to cause weight gain. It will not cause weight gain in all patients, but in some patients, it can cause a lot of weight gain. So, what you're going to do is, you're going to stop pioglitazone, change to a drug which can induce some amount of weight loss. So, dapagliflozin is an SGLT2 inhibitor, which is one of the few anti-diabetic drugs which causes weight loss. So, I'll just show you a list of drugs, anti-diabetic drugs. This is especially for those people who treat a lot of diabetes. When you see patients with diabetes and obesity, what are the drugs we should be careful in using? Now, if you look at the first 4 drugs, pramlintide is not available in India, so let's not talk about it. Theoretically, metformin can cause weight loss, but in real practice, metformin is weight neutral. It does not cause weight loss. So, telling patient that I'm putting on metformin, you'll have weight loss is probably not very, very correct. They're not going to have weight loss. These are the only 2 anti-diabetic drugs which can actually cause weight loss. One is a GLP-1 receptor agonist, the other one is SGLT inhibitors. So, if you see obese diabetics, and if you can use one of these 2 drugs, nothing like it. There are a lot of benefits of these drugs beyond glycemic control. Now, that's out of the scope of today's talks. Benefits with regard to cardiorenal complications. So, if you see an obese diabetic, try to use these drugs early on to cause good control of sugars, to cause weight loss, and to give that extra benefit in terms of cardiorenal benefits to your patient. Now, these are the drugs. I put biguanide also in this category, which are weight neutral. So, biguanides, alpha glucosidase inhibitors, bile acid sequestrants. Again, this is available in India, but we don't use it as an anti-diabetic drug. DP4 inhibitors, again, bromocriptine, fast-acting bromocriptine is available as an anti-diabetic. We don't use it very often, just for completion's sake. And these are the drugs which cause weight gain. Essentially, sulfonylureas, glenides, insulins, and glitazones. So, these are the 3 or 4 drugs which cause weight gain. So, when you start a patient on these drugs, you have to give that extra push for the patients to be a little more strict with their lifestyle. This is the second case of 45-year-old female who comes with weight gain. So what we see here is that she has periorbital puffiness. There is those pictures, there is the photo is not very clear. So this patient underwent regular evaluation and was found to have hypothyroidism. So this is one, as I said, one of the cases where you have weight gains. Start them on thyroxine, some amount of weight loss will take place. But again, I would like to stress one point here. If somebody comes to you with 10 kgs of weight gain with TSH of 100, please don't reassure them that all the 10 kg is going to go away. It's not going to happen. They may lose 5-6 kilos, but the remaining 5-6 kilos they'll have to put in efforts in terms of changing their diet and exercise. Because the whole amount of 10 kg weight gain which is there is not because of hypothyroidism. There's another case, 38-year-old female, who's 4 children. She's put on a lot of weight in the last 5 years. She wants to rule out thyroidism. This is a very, very common problem. Obese patients, the first thing they come to OPD is sir, I want to rule out thyroid problem because they're putting on weight. Because there's so much of, I would say, information about thyroid disorders on the net, WhatsApp, that every patient knows about thyroid disorders. And when they put on weight, the first thing which comes to the mind is, I have a thyroid problem. So this patient has a BMI of 33. Now, if you look at it, a TSH is a little high. So what is this condition? Subclinical hypothyroidism. The question is, how do you correlate this with weight gain? Do you think that is a cause for weight gain? Yes. This patient, probably weight gain is because of other reasons. The honest one is the weight gain that tends to occur in the peripartum period. In a woman's lifetime, there are 3 periods when the tendency to put on weight is very, very strong. Pregnancy, postpartum period, perimenopause. And in these 3 times, if she is not careful about her food intake and physical activity, they will put on a lot of weight. And socially, during pregnancy and postpartum period, they are overfed. Scientifically, they need 300 to 400 calories extra. But an average woman in India consumes 1500 to 2000 calories extra during pregnancy and postpartum period. That is the reason most of the females will put on a lot of weight in pregnancy. So the trend you watch, if you look at, if you have patients who are following up with you regularly, as I said, if you're using EMR and they're following with you regularly, you have their weight records over the period of time. What you'll see is, in their 20s, early 20s, before they get married, they'll be like normal weight. In one pregnancy, they would have put on 6-7 kilos, 2 pregnancies. So by the time they reach their mid 30s, 2 pregnancies, they would have increased by 10 to 15 kilos. And then they have a real effort to try to lose that weight. So this is one reason. And once you get into the habit of eating more, your appetite increases. Coming back to normal is difficult. Like yesterday, we were discussing about sportsmen, who eat a lot of food because when they're doing exercise and they're indulging in sports, they eat that extra calories. And when they leave the exercise component, it's very, very difficult for them to reduce that intake of food. So they tend to put on weight suddenly post their retirement. Now, in this patient, probably the TSH elevation is because of obesity related. Normally, what is seen is that increased leptins, which is common in obese patients, tends to increase TRH and can cause increase in TSH up to 10. So, if you see an obese patient with a subclinical picture, please don't jump to a conclusion that the patient has hypothyroidism and that's the cause for weight gain. Whenever you see an increased isolated TSH for the first time, always think of other causes of increased TSH before starting them on thyroxine. We routinely see patients who are put on TSH of 5, 5.5 on thyroxine and they really don't need it. And they have this thing which is being put in their mind that you have hypothyroidism, now you will be on medicine for a lifetime. So many of them we stop medications. You would not believe it. There are patients who have been on medicine for 10 years. Now they've been so nicely brainwashed that when you try to stop those medicines and tell them you really don't need it, you don't want to stop it. They're scared that something is going to happen to them. So be very, very careful before you start a patient of subclinical hypothyroidism for an isolated value of 6, 7. If it's more than 10, yes, they warrant treatment. Less than 10, look at all the other causes and then take a call. Case 4, 31 years old lady who's put on a lot of weight. She complains a lot of fatigue. She has a lot of facial plethora. You can see a lot of redness. She has hirsutism. She has proximal myopathy. You can see the striae. These are wide, purplish striae. Very classical What? Bruise. Anybody can guess? Yes. The patient has Cushing's, had Cushing's disease, was evaluated, and the patient underwent, there was a pituitary adenoma. The patient underwent transcranial dissection of the adenoma, and you can see the change. This is at presentation, this is postpartum period, the 3 months. You can see dramatic change in the looks. Again, as these are rare causes. So when you see a patient for the first time with obesity or weight gain, think of it as a normal, the garden variety of obesity. Don't think of it as hormone problem and things like that. Those are all rare causes. This is one point which I would like to stress, and if that is one take-home message from this talk, I think that will be really good. Now, when you talk about, I've already shown this slide that these are the organ-specific problems that we look at or we try to assess when you see a patient with obesity. For that, a lot of these things you will come to know from history itself. Now, for example, PCOS, you have a patient who's put on weight, who has oligomenorrhea, plus minus hyperandrogenism in form of hair loss, in form of acne, in form of increased facial growth. You know, probably you're dealing with PCOS. Similarly, obstructive sleep apnea, somebody who's put on a lot of weight, and if you ask them, there's a history of snoring, and many times, the partner will come and tell that, the patient stops breathing at night, and if you do sleep evaluation, sleep studies, you will come to know about this. Osteoarthritis, these are all very, very obvious from the history itself, from the examination itself. We do a few basic tests like sugars, lipid profile, a thyroid test, LFTs and uric acid, just because hyperuricemia is very, very commonly associated with obesity. Now for most obese patients, these tests are more than enough. If history gives you a suggestion that patient has a lot of sudden weight gain, their features of Cushing's, then you can look for specific tests to rule out Cushing syndrome. So we do something called overnight dexamethasone suppressed cortisol. Those are very, very uncommon things. The clue here is that sudden weight gain, that's what you should look for. Coming to management of obesity. The first and the foremost thing is nutrition, physical activity, behavior therapy. This is in that order. Pharmacotherapy and bariatric surgery. Now, the reason it is in this order, I'll explain to you in the next slides. So, let's look at the goals of treatment. You see an obese patient, what are the goals of treatment? Is it to get your patient to look like a model? The answer is no. Is it to get your patient to the ideal body weight? Again, the answer is probably no. Somebody who's 100 kilos, weighing about, height is 156, 157 centimeters. You cannot achieve 40 kgs of weight loss. So you're just being, if you tell the patient that we will come back to your original weight, you're being impractical. Getting patient to lose 5 to 10% of weight, yes. So if you are 100 kgs today, and you're able to achieve in the next 6 months, you're able to come down to 92, 93 kilos, you've done a wonderful job as a doctor, and the patient has done a wonderful job for himself. Get patient to exercise and reduce your activities, definitely, that's your aim. Now this is something which you should not be doing, right? How, you're trying to burn your fat by, this is something which should definitely discourage. Right, now we'll talk about how much of weight loss is going to give you benefit in terms of improvement in risk profile. You can see here, just 3 to 10% of weight loss can have significant positive effect on sugars, blood pressure, lipids. So somebody who's weighing 100 kilos, even if you come down to 95 kilos, you can have a significant positive impact. That's what is your aim, to start somewhere. Next one is NFLD, 10% weight loss. I like to bring one particular issue here. NFLD is the next pandemic that we are going to face. Non-alcoholic fatty liver disease. Now the name has changed. Essentially NASH. Most of the cases of chronic liver disease we see now are NASH related. Our hospital has a very, very active liver transplant program. And a lot of these patients have diabetes, and they develop diabetes from commonly associated with that. You would not believe it that over the last maybe 1.5 years, they would have done close to 15 to 20 liver transplants. And out of that, probably 1 or 2 are alcohol related liver disease. 15 of them are NASH related CLDs. It's so common that all doctors who see diabetics in big numbers should start exploring NASH as one of the complications of this thing. So you should definitely get an LFT done. There is something called FIB4 score, which is available on the net. Start looking at that, pick it up early so that you can do something. It's for the last 5-6 years, it's been amazing that a patient has been following up with you for the last 7 years, 10 years. You will never bother to look at NASH, and one fine day comes with a report which shows cirrhosis of liver, and the gastroenterologist labeled it as NASH-related CLD. Very, very common. So I think all of us who see diabetes should develop a little awareness for this complication. The problem with NASH is the treatment is not good. The only treatment available is liver transplant. Otherwise, it's a very bad disease to have. Worse than having even CKD. So even a 10% weight loss can make a positive impact in an infertility. Osteoarthritis again 10%, PCOS, fertility 10%. So on average, if a patient just loses 10% of weight, all these parameters will improve, and that's our aim. Now, when we talk about treatment, there are two approaches. One is what's called the BMI-centric approach, the other one is the complication-centric approach. Now, BMI-centric approach says that you decide cutoff. That okay, your BMI is 30, I can offer you lifestyle modification, behavior therapy, and medications. Your BMI is 40, you are a candidate for bariatric surgery. So that's the BMI-centric approach. The problem with this approach is it has a low benefit risk ratio and overall cost effectiveness is low. This approach is probably more, I would say, effective, because here what happens is you look at an obese patient, you look at the complications. Somebody who has more complications, you offer them more aggressive therapy compared to somebody who doesn't have complications. So this is a high benefit risk ratio and it's more cost effective. Somebody who has, let's say, a BMI of 27, 28, he has diabetes, he has hypertension, dyslipidemia, you can start him on pharmacotherapy. Whereas if this patient is just obese, there's no other thing. You can wait for a little higher BMI to start them on therapy. So that is two different approaches of managing these patients. This is according to Indian guidelines. So we said more than 23 is obese. So you can see here that these three forms of therapy, lifestyle modification in terms of diet therapy, exercise, behavior therapy, should be offered to all patients who are above 23 BMI. Pharmacotherapy, if your patient has no complication, should be only offered when the BMI goes above 27. But 25 to 27, if patient has comorbidities, say patient has diabetes, dyslipidemia, you should ask for, you can contemplate pharmacotherapy. Now, pharmacotherapy of obesity is showing a lot of promise, because a lot of new drugs have come in the last few years. Like some of these drugs are not available in India, but they are going to come. So it's very good to be aware about these things. Surgery, bariatric surgery, normally offered to patients whose BMI is more than 37.5. But if the patient has complication, even at a BMI of 32.5, you can offer. So if you're obese diabetic, 34 BMI, patient is willing for surgery, bariatric surgery is a good option. Now, the cost effectiveness and the potency of therapy. You can see here, lifestyle modification including diet control, exercise, and behavior therapy has very low risk and cost. But again, the potency is low. Pharmacotherapy has a higher risk and cost, potency is more. Bariatric surgery has the highest benefit, but the risk and the cost is also more. An average cost of, I don't know what's the cost of bariatric surgery in Pune and Mumbai. In Bangalore, in Mysore, we don't have. In Bangalore, the minimum cost would be in the region of 4 to 5 lakh rupees now. So that's the one. But if you look at it, the cost effectiveness or the cost benefit ratio, it's worthwhile. Because the problem that a patient is going to encounter over the next few years, it's worthwhile. So when you talk about obesity treatment, the first phase is induction of weight loss. Now, there are two approaches to it. The conventional approach is you start with diet exercise, wait for 3 to 6 months, and then you add this thing. The problem with this approach is, we know that lifestyle modification can make an impact, but it cannot make too much of an impact, especially in those patients who are not motivated enough. So you need to give them that little extra kick. That's where pharmacotherapy probably has a role to play. The problem is this part, weight maintenance. What I tell patient is that most patients believe that obesity is not a disease process. They say, I'm just a little healthy looking. That's not the way it is. When they have, we tell them that the way you are on medicines for diabetes, for blood pressure, for heart disease, you have to be on medications for this also. So This is what happens. Indefinite therapy, whatever, diet, exercise, behavior therapy, pharmacotherapy, etc. If you stop it again, you will start putting on weight. That's where we have the yo-yo phenomena. You go on diet, exercise, lose weight, 5-6 kilos, and then something triggers and they stop doing everything. Most time, again they gain weight, again they feel guilty about it, they start going. So it's very, very common in diabetics. So the net result is 0. 5 years down the line, they'll be exactly where you have started. They were lost weight, gain weight, lost weight, gain weight. Now, brief thing about diet and exercise. This is the pillar of managing diabetes. Managing obesity and obviously diabetes. Unless and until patients pay a little attention to this, the next 2 steps are really not, I would say, you can induce weight, but you cannot maintain it without having proper adherence to diet and exercise. The general principle is the food intake needs to come down, then the energy expenditure has to go up. At the end of the day, if patient does not achieve a negative energy balance, they're not going to lose weight. A lot of patients come and tell us, sir, I am controlling my diet, I am walking, but they don't lose weight because whatever they're doing is not enough to achieve that negative energy balance. What we say is that at the end of the day, you need to have at least a 500 kilocalories negative energy balance. Probably you reduce your food intake by about 300 to 350 calories, increase your physical activity by another 150 to 200 calories. So you have a net 500 kilocalories deficit at the end of the day. If you are able to achieve that, probably you lose half a kg per week. At the end of 1 month, you may lose about 1.5 to 2 kg. As I said in the beginning, you need to burn 7,500 to 8,000 calories to lose 1 kg of weight. So you can calculate and see 500 calories per day, 7 days, 3,500 calories, so you lose about half kg of weight. I mean, I'm giving it a very simplistic manner. There are a lot of other factors which come into play. The general principles hold good. There is no high funda diet modification. The diet, what we consume, most of us, is very high in carbs, fat, saturated fat, trans fat, very low in fiber, move and food. What patient needs to do is reduce overall calorie intake. And how are you going to do it? Simple things. The first step that I tell patient is to stop snacking. It's easier said than done, but that's the most important thing. Because what happens is when you ask a patient to recall what they eat, they'll only tell you about the main meals. They'll never tell you about the snacking part. They'll say, okay, morning I ate 2 chapatis or maybe 2 dosas, afternoon I ate 1 bowl of rice, 1 ragi ball, evening I ate. If you ask them one, they'll never ever recall that. You need to be you have to prod them to get them. Okay, after breakfast, before your lunch, did you eat something? Did you eat something in the evening? Then he'll say, yes sir, I went and had something. So they'll forget snacks. The main meals they'll remember. So at the end of the day, you need to reduce calorie intake and there has to be increase in complex carbs, protein. Essentially, you want to change calorie dense food to less calorie dense food. We've had a very wonderful session by Dr. Geeta yesterday about all these issues, so I'm not going to go into details about this. But what is important is all those, what I tell patients briefly is that 4 components need to be reduced from your diet. The first one is sugars as far as possible. Sugary stuff should come down. Oily stuff, deep fried stuff should go down. Snacking between the meals should go down. And if you are taking a lot of non-veg, that need to be moderated. So these are the 4 major culprits. And then the second thing is portion control. So 2 more major things, if you have to tell briefly to a patient. See, most of us doctors who don't have access to dietitian, if you have to talk about diet to a patient, what you have to stress is the core points. Reduce these things. Snacking to be reduced, portion control to be managed. If you can manage these 2 things, at least 60-70% improvement can be expected. Then probably if that's not working, then you definitely have to take a help from dietitian. Exercise. You can see here, walking 2 miles per hour, just 200 calories. Now this is something which all your patients will tell. Doctor, I walk every day for 45 minutes. Now you need to ask your patient, 45 minutes, how many calories will you burn? Probably 150 calories. You sit, have a cup of tea, with 2 or 3 good day biscuits, you get 150 calories. So where are you going to? I mean, there's no negative energy balance. And you don't, when you are sitting and recalling, you remember that every day I walk for 45 minutes. But you will not remember that every day after I come back from work, I have a cup of tea and 3 good day biscuits or 4 good day biscuits. That you will not remember. So you are not going to lose weight. So the most important thing in any weight loss program is a greater attention to food intake, then exercise. Exercise is important for weight maintenance. for weight maintenance. But exercise per se will not be able to induce weight loss if there is no reduction in food intake. That's something which, because exercise, you don't burn too much. It's something, unless you're doing really strenuous exercise. What most people do, 30 to 45 minutes of walk, you will not burn more than 100 to 150 calories. This is important. Set reasonable expectations. Whatever program you start should be gradual. Most obese patients who are sedentary, you need to tell them to start walking 10 minutes per day. After a week, make it 20 minutes, then 30 minutes, and then 40 minutes. That's how you should step up. Same thing with healthy eating habits. You can't tell them, from tomorrow, stop eating this, stop eating this, stop eating this. Nobody's going to follow that. It has to be a gradual change in their eating pattern. This is a goal. You tell them that our goal is, you are 100 kilos today. In the next 6 months, I want you to lose 8 to 10 kilos. What happens is, a lot of patients will come because of all these wellness programs and slimming centers, VLCC and things like, which will advertise, lose 5 kilos in 5 days, lose 4 kilos in 4 days. So they come with those expectations to doctors. So I tell them very categorically, I don't know how they are able to do it. They'll come and ask me this question. Doctor, when I say that you are not going to achieve 5 kilos in 5 days, so how are they able to achieve? I said, you go and ask them. I don't know. I have no idea how they do it. So you said 5 to 10. As I said, if you are able to achieve 500 to 600 negative energy balance, probably you lose about 1.5 kilos per month. That's good enough. Rarely do obese patients achieve ideal body weight. Falling short of these lofty goals, which is very, very common, tends to discourage patients. And then they'll go back to their old eating pattern, old lack sedentary lifestyle. So you have to follow the middle pathway. And what we should tell the patient is that we don't want you to lose 20 kilos. We want you to just start with 5 kilos weight loss so that whatever metabolic derangements are there, they'll start improving. That's what we have to stress. Now, just a word about the drugs which are there. Now, these are the 6 drugs which are approved by the FDA. Now, some of these drugs are not available in India. Orlistat is available. It's one of the oldest drugs. You can see 1990 there. Essentially, it inhibits fat absorption from the gut. So now Orlistat is not a very potent drug, and it will only work in those patients who have increased intake of fat. It's like there's a catch there. Catch here is that when you give Orlistat, we tell them to have 1 capsule before each meal. You have to cover each meal. You have to be very strict in telling them they should not snack between the meals because it will inhibit fat absorption in that particular meal. So if the patient has 6 meals a day and you give before 3 meals and 3 snacks, he's not going to lose weight. So when you give Orlistat, always tell patients no snacking between meals. Each meal should be covered with the capsule. The second thing to be kept in mind is you should forewarn the patient that if any meal they have increased amount of fat, they're going to land up in bad case of diarrhea. And that is something, so that if you forewarn, the patient will be careful. It's like, now what we say, it's like a alcohol, you give them disulfiram, the same kind of this thing. So they, over a period of time, they realize that if they eat fatty food, they land up with loose motion, they avoid eating that. That's how it works. But most patients will not lose more than 2 to 3 kilos of weight. You cannot expect them to lose too much of weight. These 2 drugs are not available in India, so let's not. Liraglutide is available as an anti-diabetic drug. If you remember, the dose as an anti-diabetic drug maximum is 1.8 mg. This is a 3 mg dose which is not available in India. I don't think so it's approved for weight loss in India.
No, it's not approved.
So liraglutide is the same liraglutide which comes with the trade name of Victoza, which we use for diabetics. But there the dose is 1.8 mg. This is a higher dose of liraglutide, approved by FDA but not available in India. It's definitely important. Then you have these drugs. Again, these are not available. This is labeled as a medical device, something like super absorbent hydrogel particles of cellular citric acid matrix. So it gives you increased satiety. Again, not available in India. This is specifically for one of the monogenic obesity which I showed you, one of the slides, MCR4 mutations. So again, this is not for your normal diabetic. Semaglutide has a lot of promise. Again, semaglutide, what's available in India is the oral semaglutide. Now both IV and oral semaglutide have been shown to cause weight loss, but as of now only the IVs are approved in subcutaneous. Subcutaneous weekly once preparation, 2.4 mg once a week. Again, the dose which is used in diabetics as an anti-diabetic is 0.5 mg weekly. There, this is a higher dose, 2.4 mg. And you have the oral semaglutide, which is available in India. There, the maximum dose in diabetic is 14 mg per day. But as an anti-obesity, the dose that has been tried is 15 mg. It has showed a lot of a very good response, but it's not approved. So all these drugs are available for obesity, out of which only orlistat is available in India. Liraglutide, you can use it. It's not indicated, but off the record you can use it. These other drugs are not available. There are a lot of new drugs which are in the pipeline. Probably Vaishali will tell them because she is into obesity trials. Vaishali will probably comment here. Vaishali, you want to say something? Newer drugs about obesity.
So obesity treatment focuses around three things nowadays. It is mainly the enhancement of basal metabolic rate. So there are RE, the resting energy expenditure increases, and that's a big set of molecules which is not put up over here. If you remember, sibutramine was one of that in the category. It has been now out of the market because of its cardiac side effect. But what we call as in layman fat burners, the ones which increase the metabolic heart rate. So that's a set of population of drugs. And second is those which act on the GI, the gastrointestinal tract. And these are the group of orlistat category of drugs which inhibit fat absorption. There are certain antagonists of neuroendocrine systems. So drugs which decrease the gastric motility, they act on, in fact, there are other mechanical stimulators of vagus also. So there are certain techniques which is known to change the vagal pacemaker of the gastrointestinal tract. I told you yesterday that it's like switching on the button. So that switching on, that electric wiring of the gut is changed, so with certain medicines, and also there is a mechanical pacing of the stomach pacemaker, where you change the motility of the GIT and make it more slower than usually obese people are known to have very high GI motility. So that pace is slowed down because the faster the motility, the hungrier I feel. So I feel like eating every time when my motility is high. So when I slow it down, I feel full all the time. I don't feel like eating. And the third mechanism, which predominantly is very important, is controlling the brain, the satiety action and the appetite regulation. So this center, we know we were talking about amygdala. It is mainly in the amygdala and in the periventricular nuclei which surround the third ventricle. And this is what is the important focus now. So it can go from stimulation of that particular area with like something like a ECT, where you are changing that set point of obesity. So why it happens that the person rebounds? Because there is a set point in everybody's body for weight, for temperature. You see that some people feel cold, they are always cold, and some people tend to be warm all the time because they have a thermostat which has been set at particular temperature. Similarly, appetite, each one has a different appetite which is set. I can't eat more than 4 chapatis. That is what somebody would tell. Somebody would say, I can't eat more than half a chapati. So each one has a, you can say a stat, thermostat, a weight stat and a osmostat set up naturally by birth. And that is why the body always tries to take it as a threat. When I am trying to change the weight, my body perceives it as a stress. What it perceives that I am under a stress of change of my weight thermostat or a static, you can say a set point. My weight set point is trying to change and I need to act. That is why the moment you start losing weight, body takes all efforts to get it back. So this is the mechanism why your set point is the balance around which your body will always try to get your weight to that level. So what is my job? Either as a doctor I can change that set point. So how do I change that set point? Is with drugs where they will act directly on those nuclei where the set point is uska alarm alag tarike se set karega. So my set point will be made at a lower weight. Suppose I am 100 kgs, I will try to shift that set point to 90 kgs with the help of certain drugs which will act on those nuclei, or I can directly give a current to that area. So I can give a ECT to that area which can change that set point. So lot of drugs in this category of leptin agonists, NPY receptor agonists, GLP-1 analogs, GIP analogs, combination analogs, triple agonists, All these drugs. There is a new drug which is also approved, tirzepatide. So tirzepatide is a big blockbuster molecule. It's a Lilly product. It is available in the European market, and it is known to give nearly up to 20% weight loss within a span of 6 to 8 months. And tirzepatide is going to probably see the Indian market also in coming couple of years. And we have, that is a dual agonist. Dual agonist means GIP and GLP. Now what are these agonists doing? They are acting on the GIT, they are slowing down the gastric motility, they are acting on the brain, controlling my appetite, they are improving my satiety. I feel full early, I eat less, and in addition there are certain beneficial effects on the adiposity. So it is reducing my visceral fat. So obesity is now a multifactorial and multicellular disease. It is not what it was thought of, that it is only a BMI based mechanical thing. Second important thing is treatment now focuses on functionality of the disease. So how functional is that disorder? So there are 4 obese people in the crowd, and you have one who has severe osteoarthritis, is bedridden, versus a obese person who has a myocardial infarction and has diabetes, versus a obese person who is 80 years old, who is active, who is moving around, has no illness, and versus you have an obese person who wants to conceive, who is having ovulatory problem. And all these scenarios of treatment are different. So it is not one single protocol for all 4. The person with a lot of functional disorder, the emergency for need of therapy, is the person who is going to take treatment. Now obesity is also a mind disorder. So I have seen 60 kilos people coming and saying, "Madam, I have gained a lot of weight, I want to lose it." So it is not the obvious weight that I am seeing, it's a weight in the mind. So I have helped those patients to come back to 50. Why I helped them to come back to 50? Because they were always 50. But they can't take that extra weight. Their mind can't take that extra weight. They feel that heaviness immediately. And what is important for us to understand that ideally, if I knew this earlier, it was an easier job. But now it is said that at the age of 25, whatever was your weight, that should be a lifetime weight. There should be no change in your weight after 20 to 25 years of age. Neither a fall nor an increase. If it is changing after the age of 25, it is going to be a disease fat. It is not going to be a healthy fat. So especially the pregnancy weight, the postpartum weight, the menopausal weight, all these weights are problematic weights, and one should always, though the ideal weight is far from the target weight, you don't always achieve that, but your aim lifetime should be to achieve what you were at 25. So this should be your constant aim of treatment. And I always tell my patients that it's not so important to get your weight to the target. It is important to have the effort. The effort is the benefit. It is not the end result. So a person weighing say 130 kilograms is able to say go to 125 kilograms only over a span of 10 years. It is beneficial if this person has been following all these things day in and out. He will still be protected from ill health, and the targets of therapy will be achieved. So it is not a matter of 130 kilograms coming to 80 kilograms and becoming hypertensive, diabetic, or stressed out, depressed. So that doesn't make sense. So the person remains healthy and he continues his effort for maintenance. So what as an endocrinologist we feel is that obesity treatment is a lifetime effort. So induction of obesity treatment definitely needs drug, but lifetime maintenance definitely needs behavior. And that's the role where psychologists, psychiatrists, nutritionists, wellness coach do play a lot of importance and role.
हमारे यहाँ बोला जाता है जिस ब्लेजर में आपने सर्विस ज्वाइन की है उसी ब्लेजर में अगर रिटायर हो गया तो यूर मेन हेल्थ
At 25 blazer and at 68, it should be
should retire the
So
same blazer.
yeah, I agree with you. My husband keeps on checking his marriage blazer all the time, and he is very proud to say that I can still wear that today with the button still tightly pinned up. So I agree with you. I think blazer at the time of your marriage is the right thing, and I always keep my own clothes because they remind me that I have to get into them.
Thanks. Yeah.
Yes, Doctor.
Yes.
As far as obesity is considered, we have not, and suppose up to this talk, we have not come to some important conclusion, findings, and research where the mind is involved. As far as the things are concerned, there should be some thing that we should measure that obesity has increased something in the brain, in the form of brain feels heavy. It may be whatever hypothalamus, thalamus, and amygdala and whatnot. One of the important molecule that has come into market and gone, that was not very come into this practice, which may affect brain-gut axis, which was thought to be part of obesity as well as diet is considered, is bromocriptine. And it has come and gone. That is I am saying, and it can be explored in a different manner, where it is going to affect. It has actions on brain. So this molecule is yet to be not completely explored and explained in this treatment of obesity. One of the important factor that two questions I have not got answer. Why the mind is called as diabetic mind? What it means to us and why we want to mend it? One question. And another one is why. Another question is. I think we are supposed to going to discuss, but may not have discussed about the sexual health in all this scenario, diabetes, obesity, and mindfulness, because good sexual health is also important as well as we think of good mindfulness and these things. So I think 2-3 questions and experts are there, so they can answer these two.
Can I answer this first question?
Yes, sir, please.
Yes. So I'm happy that the MCN in him has arisen finally. So let the Nimansian in me also arise. To rebut his. Yes. We avoided talking about the mind and what has become heavy, because that has been the topic of very heavy discussion, the amygdala. So I will forward you a couple of references, very interesting studies actually carried out by the oncology people. They do the whole body PET scan. So sometimes people get, like we saw, Archimedes moment. So these oncology guys, they got a Archimedes moment that let us also, since we have the whole body PET available, let us look at the metabolic activity of amygdala. And they found two important things, that amygdala metabolic activity is the best predictor of visceral fat. Then came the next group. They said that, okay, once this finding looks reasonable, done on a reasonable, they both are published in high value journal. One of them in a medicine journal, another one in a endocrinology journal. I will immediately forward you the original papers also. Then the second people, they thought that let us look at now the entire mechanism also. That how does amygdala, which so far has been concerned so much with anxiety, we have been speaking only about the anxiety, psychiatry mainly spoke about anxiety, threat, etc. So how is it, kind of translating this into this? So the other group came out with something very interesting and even more startling. They said that not only it is you can say a good marker, metabolic activity in amygdala, good marker of visceral fat, but the next group said that this is also perhaps one of the best markers of the cardiac risk, what we have been discussing about the autonomic. And they traced then the whole thing, so it works basically through the inflammatory mechanism. Amygdala to bone, to the fat and to the heart. Elegant, absolutely. I say that maybe we have to ask actually such people that what was their motivation, to measure the amygdala activity. Then we can link it with a third study, which is a Rotterdam study. Rotterdam also incidentally has one of the less known cohorts, Framingham cohort, ECA cohort, more named cohort. अपनी epidemiologist colleague किधर है? रंजन है नहीं तो इधर ही है. उसको पता नहीं होगा उसको. शायद Rotterdam cohort का. Few people know about Rotterdam cohort. So in the Rotterdam cohort, as you know that Europe had this long tradition about people's awareness about health matters. And Netherlands in particular is considered as a bicycle capital of the world. पता है आपको? It also has a lot of guys, because Netherlands was the place where famous Maharshi Mahesh Yogi put his headquarters. जिनकी वजह से ट्रांसेंडेंटल मेडिटेशन आया है ना, अपने को ये बहुत सारी चीज पता नहीं होती है. तो रॉटरडैम पीपल फॉर सम रीजन they in their Rotterdam study which they did something which Framingham and ECA did not do. So they asked also people कि भाई आप लोग क्या करते हो? And they picked up a lot of guys, those who were doing yoga. And then they also had actually, this amygdala thing. And they found that people who are doing yoga over a period of time, you can reduce, actually this metabolic activity in the amygdala. So we know the role of amygdala in this whole story. That amygdala causes, it's a major, in fact, there are studies now, someone was asking me about the childhood trauma, psychological trauma. Now, a whole, you can say, life course, natural course is available that how does actually in a childhood the amygdala hypertrophy can happen, precocious functioning of amygdala, then how it burns out and how it sets, seed for actually that obesity, which is perhaps the reason in many of these people. So there is a huge amount of information which is becoming available about this whole amygdala and its role. Then it so happened that the semaglutide people, we had this, they introduced it in India. Vaishali was very kind to invite me also, to a couple of those meetings. I have that slide, I will show you the slide. So the meeting was for the naturally general physicians, etc. But also companies also sometimes try to show they are very academic. So they put up actually a PET scan picture there of the animal model. Where does the semaglutide exactly work in the brain? It works on the nucleus of vagus, the tractus solitarius, and it works on amygdala. I will show you, I have the slide. I requested actually the Novo Nordisk people to specifically send me the slide. And that's why this whole discussion since yesterday, sir, coming back to your question that you have been asking, कि भाई इसमें brain में क्या heavy हो रहा है? तो brain में most important organ which is getting heavy in this whole obesity story. क्योंकि क्या है ना, if you ask me again, how do I look at obesity? One of the important dimensions which is missing out in this whole story, it's somewhere I look at them as the brain, their brain is in a discontent state. संतोष नहीं है brain को. We know that संतोष as one of the niyams, carries a very important kind of a value there. क्योंकि क्या होता है कि जैसा amygdala तो अपन बहुत बात कर रहे हैं वो threat वाला organ है. पर ब्रेन में, let me not get into unnecessary anatomy detail of brain, but there are other parts also which represent satiety, security. तो ब्रेन में ऐसे भी पार्ट है क्योंकि ब्रेन में हमेशा पेयर रहती है. इंसुलिन ग्लूकागॉन जैसा पेयर है ना, तो ब्रेन में भी वैसे एंजाइटी बढ़ाने वाली भी पेयर है, पर एंजाइटी को शांत करना, सटाइटी को बढ़ा, और सटाइटी यानी नॉट ओनली एट अ विसरल लेवल, साइकोलॉजिकल सटाइटी. पर मेरा पर्सनल ऑब्जर्वेशन क्या है माइंडफुली मेरे खुद के बारे में, मेरे को ऐसा लगता है कि मेरे को बहुत फूड की क्यों हंगर नहीं है, क्योंकि मेरी सटाइटी बहुत सारी चीजों से आती है. मैंने बहुत सारे लोगों में ऑब्जर्व किया है कि जिनको बाकी जिंदगी के बहुत सारे एरियाज में सटाइटी कम होती है ना, उसके लिए फूड इज वन ऑफ द मीडिया विद व्हिच, बिकॉज़ यू हैव टू सैटिस्फाई समहाउ योरसेल्फ, संतोष प्राप्त करना है. तो आपको यदि अपनी जिंदगी में संतोष है ना, तो आपको है ना उस सोर्स से उतनी सटाइटी की जरूरत कम रहती है. तो इसलिए वो amygdala का कनेक्ट, तो amygdala है, amygdala के साथ में anterior cingulate and other areas, our functional MRI champion is here. We can have a match between Ems and Nemans, we can go the whole day. In my days, we were taught never to lose with anyone in this world, so you cannot beat us, in terms of the information and in terms of logic, we would bash any team anywhere, but we don't want to do, because we are yoke people. Because the value of santosh, it teaches us also to be content. अपने को आज कुछ पता है, because we are here, so we have to be honest. Science knows up to some level. We are here, because science doesn't have all the answers. Maybe it will have, someday. So
if I can add to his question, why diabetic mind? So I'm sure everybody of us knows as physicians that octet and 8 to 10 organs which are involved with diabetes. Very less is known about the brain as an organ for causation of diabetes. We know that the effect of diabetes on the brain is well known. We know neuropathy, we know dementia. What is known that brain can cause diabetes? Nothing is known. So why we are talking so much about the brain, not talking about diabetes, is to understand why diabetes is occurring because of the brain. So why the prefrontal cortex needs to be built up to decrease brain gluconeogenesis, to help the metabolism. So if you can understand at the end of 4 days that all this that we spoke, if not taken care of, is going to cause diabetes. So why I am talking about this is no book will mention this. Why? Because this has not been studied. Why this has not been studied? Because endocrinologists don't know it. So neither do physicians know it. Why? Because it is a unique thing to have an integrated group. There is no group in the world which has integration of neuropsychiatrists, the brain specialists, the neurologists, the metabolic people all coming together. So I think thanks to Phadke sir and his mindset that he sees that vision, that the disease like diabetes which affects every system of the body has its causative role in the brain. And there are a lot of experimental studies. It's a lot of food for thought for physicians, endocrinologists to understand that brain is causing diabetes. Have you ever seen diabetes occurring in a very contented man? You'll never see that. You'll see in a type A personality, you'll see in an executive personality, a person who is jealous, who has hatred, who has anger, who has rage. You'll never see in a positive person, a peaceful person, happy person. You forget the environmental factors, forget obesity, forget wrong eating, forget exercise. If these people are mentally healthy, they will never have diabetes.
So
they will never
obesity
have obesity.
can be seen as actually from yogic viewpoint can be seen as a disorder of hoarding. And why does that hoarding happen? Parigraha. And why does that hoarding happen? That hoarding happens because of
insecurity.
several other. It can happen because of attachment. It can happen because of fear.
You should be able to let go.
ये देखिए सर, ये this is courtesy Novo Nordisk. So thank you Novo Nordisk for this. Hypothalamus, central nucleus of amygdala, most active. You can see central nucleus of पेट में activity सबसे ज़्यादा है यहाँ पे. And the nucleus flectus solitarius. This is the nucleus of vagus. What Lina showed us. This is the nucleus of vagus. And this is the nucleus of amygdala. Two most active points. Okay.
Sir, and
So today I think we want to morning में अपना एक man को जिससे vagus छोटे से measure से definite stimulate होती है आज
वो खुद ही बताएंगे ना.
वो तो वही बताएगा.
वही बताएंगे.
छोटे से measure से HRV से measure किया हुआ है.
Sir, the only thing is, sir has already talked about it that obesity, there are two ways in which it occurs. One is the homeostatic mechanism and a hedonic.
Right.
So these drugs, they might be acting on a homeostatic, but the hedonic is through MBM.
That's right. And second question,
Hedonic, how we are going to achieve control the hedonic part of this obesity?
That's where the behavior therapy is.
Yes, yes, yes.
I think the next part is going to be by
Exactly. Exactly.
So the second question which you asked was why was sexual health not spoken of? I think sir has answered it partly that satiety, whether it is for sexual health, whether it is for success, whether it is for satisfaction, all that satiety is essential, and if that is not taken care of, so sexual health is one of the important rhythm of life.
I think Dr.
So
Sandeep is going to talk about that.
Okay. So
He
he's
will talk
going
about
to, yes.
containment in
So-
life. He is going to speak about.
So there are 5 rhythms which we actually are lacking time. So I hope that we are able to talk sometime in the day. Sleep disturbance, sexual health disturbance, appetite disturbance, vitality disturbance. All these are known to be causative for
and
diabetes.
the mind
And
disturbance.
So,
mind cluster.
Mind cluster. So all this you can say any dysrhythmia into this is going to cause all the NCDs, not only diabetes. So there is one day to be spoken on each rhythm, and there is lot of us to learn. So I am sure that if this would have been a 10 days retreat, we would talk more on yoga, on different poses, how they would change the rhythms and many more things. But I think this is a consortium to give you a hint about a little bit of tinge, jalak, about each and every factor.
But what I am most happy about is that we are on a very high level of discourse, and greatly actually thanks to you.
Yeah.
Yes, I know he
been
has.
actually, you should do it. You
Yeah,
should
give
ask
a round of applause for Dr. Amar.
Absolutely.
He has excited real good discussions
So no
because
hard
of his.
feelings are between imams and collaboration.
Carry on. Your chances of missing the point is high. Go back to the PPT. You can carry on.
In fact, that particular last slide which I was showing, which showed the 6 approved drugs. Out of those 2 drugs, liraglutide and semaglutide, these are GLP-1 receptor agonists. What Dr. Vishali rightly said, they act by increasing satiety and also by slowing gastric emptying. So you don't feel hungry very often and you eat less. So to some extent, it controls your hedonic pathway also, because when you're feeling full, obviously you're not going to binge.
Please go to the slide.
Yeah. Now the next part is about the last part. This is the last part of my talk. It's got a word about bariatric surgery. Now, when we talk about bariatric surgery, as of now, probably bariatric surgery is the most effective way of inducing weight loss in a morbidly obese person. Okay, I'll do.
Jhatka treatment as well.
Yes, Jhatka treatment. Good.
Unfortunately, it doesn't really treat. We see a lot of rebound because it never controls the pathogenic cause.
Now, so these 2 drugs, probably from a doctor's perspective, I think the problem is obesity now is that when we talk about therapy to our patients, we can offer things like diet, exercise, behavior therapy. But unless and until patient is motivated enough, those things don't really give you such good results. So from a doctor's point, it's very frustrating. You tell patients, they'll come back, there's no weight change. So these drugs definitely help, especially the newer drugs. So let's see when they come into the market, probably in the next 2-3 years, what promise they hold. A word about bariatric surgery. Now, there are 2 different types of surgery. One is the restrictive surgeries. This is what is called the vertical sleeve gastrectomy. What they do here is, they remove the larger portion of the stomach, and the stomach is made like a tube. So obviously, when the size of the stomach comes down, you eat less. The other thing which happens here is that you're removing the greater curvature of stomach, from which a hormone called ghrelin comes, which is a orexogenic. That's the hormone causes you to eat more. So that's how it works. So this is the very basic surgery which is done. Then you have these 2 surgeries. These are malabsorptive surgeries. So what they do is, you can see here they have bypassed a portion of intestine. Here it is a larger portion of intestine, small, where absorption takes place. So these surgeries are a combination of restrictive and malabsorption. So whatever you eat, it doesn't get absorbed. And then you have something called the adjustable gastric banding. This particular thing, what they do is, they'll put a band around the lower part of the esophagus, and there's a port which is there on the anterior abdominal wall. You can inflate the balloon and restrict the opening. Now, this is not all these other surgeries are irreversible, but this is a reversible formula. Now, where you're going to use this kind of device? Let's say somebody has obesity, somebody has PCOS. The patient wants to conceive. Now, unless somebody who's PCOS who has 90-95 kilos of weight, if they don't lose that weight, chance of conception are there, but it is less. So those are the kind of patients where you put a band for 6 months to 1 year, they lose 15 to 18 kilos of weight, and then you remove it, and then they plan conception. So that is one situation where you can use these bands. There is one more surgery called the mini gastric bypass. Here, this is a variant of Roux-en-Y, but if you look at Roux-en-Y, you have to do 2 kind of surgeries there, one here and one here. Here it's a single anastomosis which is done. So this is something which is becoming very popular. Again, a form of malabsorptive surgeries. All these bariatric surgeries work essentially by causing malabsorption. They also work by restricting the stomach as a reservoir, and in some cases by removing a source of ghrelin. There is another thing which is called the endo variant, which is not still approved. There are a lot of, what I would say, studies which are ongoing, essentially, using endoscopically, they put a barrier in the stomach, in the areas where so the food directly bypasses those areas where maximum absorption takes place, and that's how you lose weight. So it is showing promise, but it's not been approved. These are all approved surgeries which are being done for patients who have morbid obesity.
Sir, what is missing in all these gastric resection surgeries is they are all say volume limited or say, but what is important that here they are cutting the vagal fibers to the reach vagal fibers to the stomach, and that is not taken into account. Somehow, if we are dealing with the nucleus tractus solitarius, which is a vagus nucleus, and the fibers which are being cut in the surgery are to be taken into account if we really think that one of the additional mechanism of weight reduction may be through this pathway.
Again, see, that's what I'm saying. Whatever procedure you do, there are pros, there are cons, right? At the end of the day, look at what is more, the benefit is more or the risk is more. Here what happens is, all these surgeries have been shown to induce at least 20 to 25% of weight. There is no other therapy that you can offer to a patient who is weighing 130 kilos to bring him down to 80 to 85 kilos. Nothing is available. So that is the reason these surgeries have side effects. The patient has to be on supplements for a lifetime. You offer them only to somebody who is morbidly obese or who has a lot of comorbidities. You don't offer them to somebody who comes to your OPD and who is weighing 30 kilos and he says that, sir, I want to lose weight. You're not going to offer them to those patients. It's only for a selective group of patients you offer these surgeries. But I will stress one point here, for morbidly obese patients who already have other comorbidities, this is one procedure which can prolong their life. Somebody who is morbidly obese, has diabetes, has blood pressure, they have a significant shortening of their lifespan. This can make their life. Yes, there are problems, I'm not denying it. Everything has pluses and minuses. But at this point of time, the pluses are more than the minuses. Yes, if we have better pharmacotherapy, as Dr. Aarti was saying, we have dual agonist and triple agonist, GLP-1, GIP and glucagon agonist, which are likely to come into market, which are showing a lot of promise, 20-25% weight loss. When they come into the market, probably these things will go backseat. So this is my last slide. So we have evolved from this, where you look at the person here and look at what he was playing, and now we have come here and how things have changed. That's what that I would like to go. Thanks a lot.